Hello and welcome. My name is Robbie Jashinsky. I'm head of the Applied Social Sciences Group at Cambridge University. A few years ago, I was awarded a grant by the Wellcome Trust to study disorganized attachment and what its implications are for social workers and clinicians. In the course of that research, I found there's a lot of misinformation out about this concept on the internet, in books, so I wanted to assemble a panel of experts to tell us about it. First is Professor Alan Srouf, who is at the University of Minnesota. He was part of the Institute of Child Development before he retired. He was my teacher in learning the strange situation, and I'm really thrilled that he's with us to tell us about the strange situation, a key method for assessing child attachment. We also have with us Professor Eric Hesse from the University of California, Berkeley. Eric Hesse is one of the researchers who introduced the FR coding system for analysing frightened, frightening, and dissociative caregiving behaviours, and is a real expert on this topic. I'm also pleased to introduce Professor Miriam Steele, who is Professor of Psychology at the New School for Social Research. Miriam's work has been really influential in understanding clinical implications of this topic, and I'm thrilled that she's going to be able to talk to us about that today. We also have with us Professor Mary Dozier from the University of Delaware. Mary Dozier's work began by looking at clinical interactions between patients and their clinicians and understanding those in attachment terms. But in recent years, she's done a variety of studies looking particularly at infants and at interventions to improve caregiving relationships, a really important topic, and we'll be hearing from her shortly. Finally, I'm pleased to introduce Professor Per Granqvist from the University of Stockholm. Per is the recent author of a paper putting forward some proposals about how disorganized attachment should or shouldn't be used by clinicians, and so therefore is really someone who it's great to hear from on this panel. So Alan, to begin, before we get to disorganized attachment, what is secure attachment?
When we speak of secure attachment, we're actually referring to the confidence that the infant has in the caregiver. The infant's confidence that should they become alarmed or threatened or stressed, if they turn to their parent figure, their attachment figure, that person will respond to them in a way that alleviates the distress. So secure attachment means confidence in the attachment relationship. We can see this in the formal laboratory situation known as the strange situation by looking at the way the infant is able to explore in the room, turning to the caregiver only at times when there's something alarming or distressing. So typically, an infant that's secure can easily separate from the caregiver and play with the toys. Should something alarming arise, they know in a deep way that the caregiver will be attentive and responsive to them. It's this knowledge, this confidence, that allows them to explore freely. Now, not all infants show this same degree of confidence. For example, infants that have experienced chronic rejection, especially when they take a tender need to the caregiver. They take the need to the caregiver rebuffs them. Those infants learn to stay away from the caregiver at times of need. So those basic patterns are the background for how we then look at what is called disorganized attachment.
Professor Hesse, what then is the disorganized attachment classification?
Well, the disorganized attachment classification arose out of a growing awareness in the 1980s amongst a variety of researchers that not all infants could be placed in the original categories that were defined by Mary Ainsworth, who was the originator of the strange situation. And this was noted in anomalous behaviors of various kinds that some infants displayed, leading those infants to initially be called unclassifiable. Mm-hmm. Later, a series of thematic headings delineating certain kinds of behaviors that would be considered disorganized was very well specified, and and the category was then added to the strange situation, and it's been highly well tested and empirically validated.
What causes these behaviours that don't fit the original categories?
It can occur for a variety of reasons, and that's one of the things that I think is important that you're raising in this discussion here. Many things can cause an infant to appear disorganized. Just parental unavailability in a supermarket, for example, might make an infant behave in a peculiar way because they're frightened at that time. But that would not be the kind of disorganization that we're concerned with when we're thinking about disorganized attachment. Disorganized attachment stems from the relationship the infant has with the caregiver. Mm-hmm. And in this case, unlike the infants that Professor Srofe was just referring to, who, whether secure or insecure, have a singular strategy for utilizing the parent, however optimal or non-optimal it is. Disorganized infants are placed in some kind of a paradoxical injunction by the parent, usually due to some kind of alarm. And this activates both an approach and a flight or a move away tendency, which is, in essence, a paradoxical injunction.
I've got a question though. Why would a child who is alarmed by their caregiver want to approach them?
Because the attachment system is biologically channeled to create approach when there are cues to danger in the environment that would enhance survival by increased proximity to the parent. This was one of the core elements of John Bowlby's theory, and what has made attachment theory so compelling and so powerful as a research tool.
Thank you. So when we're thinking about different reasons why a child might be alarmed in relation to their caregiver, what kind of reasons might there be?
Well, there are a variety of reasons. And of course, a parent who is neglecting or maltreating would cause alarm.
Necessarily?
Yes, I think necessarily.
So would all children who have a caregiver who alarms them show disorganized attachment?
No. And why that's the case, we don't yet have definitive answers to. What we do know is that that when a parent is maltreating or severely neglecting and the like, a significant number of those infants will show disorganized behavior in the strange situation. But there are other pathways to disorganization as well.
I'd be really interested to hear about that. What other pathways are there to disorganization then?
Well, frequently, if a parent has had some adverse experience, such as a loss which for them was traumatic, loss, of course, is not intrinsically traumatic, but it can often be traumatic, or some other traumatic experience, such as sexual abuse or physical abuse of their own, who is not repeating those patterns with their own child, in that there, I guess I'm referring primarily to maltreatment, but instead still harbors frightening ideas and is prone to enter altered states of consciousness as a result of their unresolved trauma. And when they manifest fear in these altered states, they become alarming to the infant, because the infant can sense that they are not available, and they are also acting strangely, even though they may not be doing anything at all bad to the infant. And that can also create the same kind of paradoxical injunction.
So even if a social worker or a clinician was told by a clinical psychologist that with all of the best methodology possible that the child is showing disorganized attachment, you still can't draw that many conclusions from that in terms of the child's history with that parent?
Absolutely not. The way disorganized attachment is assessed is very powerful at making predictions at the level of groups, but it is not an assessment tool for individuals. The only way that you could satisfactorily address that would be to have a very carefully compiled body of additional information about both the history of that parent-child interaction, and what goes on in the home, the like.
That's really important, because I don't think that what you're saying is in line with a lot of the information out there. So it's great to hear from the experts that that's the truth of the matter. But one thing that's kind of tricky here is that if disorganized attachment isn't a diagnosis of a child at the level of the individual, how does that relate to the idea of attachment disorder, which is a diagnosis? So maybe Miriam, can you help us with this? What's the relationship between disorganized attachment and then attachment disorder? Are they the same?
They're not. There is no relationship between those two whatsoever. As Eric was saying, disorganized attachment is a very technical term that comes from coding a very specific situation, the strain situation. Attachment disorder refers usually to what we have in the current DSM, the Diagnostic and Statistical Manual, which is divided into two disorders. One is reactive attachment disorder, and these are children who have displayed this before the age of 5, have to be at least 9 months of age, and are very inhibited or withdrawn from their caregivers. Mm-hmm. So, as Alan was saying, usually a securely attached child would show proximity or reaching out to a caregiver. These children do not, even when distressed. The other form of attachment disorder that we have in the DSM are children who are disinhibited, who are, it's disinhibited social engagement disorder. And these are children who we often associate with institutionalized children. Both of these categories come from children who've suffered from extreme social neglect. Mm-hmm. And the disinhibited child is often characterized with over-friendliness, a capacity to almost seem as if they would go off with anyone and not differentiate from their caregivers who are actually invested in them and looking after them. So those are the two that really come under attachment disorder and are therefore very different from attachment disorganization, as we've been hearing.
But that's then tricky. How do clinicians register the significance of attachment phenomenon, attachment processes and relationships, if the only diagnoses available that mention attachment are these two ones that you're saying are extreme and really mostly applicable to institutionalized children? What about everyone else?
So I think that we need to help clinicians understand from the rich theoretical basis that John Bowlby and Mary Ainsworth have given us in terms of what is attachment as applied to their theory and the decades worth of research that have followed on from that. And that's very different from these two very specific disorders, which, as I say, come really from this rather small group of children who have suffered tremendously by being in institutions where the quality of care has been so poor.
I think that's quite a radical idea, because the idea of attachment disorder is very widely used. So to hear from Professor Steele that actually it really applies most precisely to children who have had institutionalized contexts, and the idea of attachment disorganization is not best considered a clinical category, it's really interesting. Professor Sruff.
One thing I think is really important for people to think about is that when we talk about anxious attachment or even disorganized attachment, it's best to think of that as a risk factor for later problems rather than a disturbance itself. It's a risk factor in the sense that those children more often will have problems, but not all of them will. And those who do have problems, often there is some kind of continuation of difficult life circumstances, rather than being simply, if you have a disorganized attachment, inevitably you will later have a psychiatric problem. The research is very clear that disorganized attachment is a risk, but it's also very clear that it's not a certainty that disorganized attachment will cause a later problem. It well merits intervention, but it is also at the same time best not to be thinking of these children as psychiatrically disturbed, these young infants.
That's really interesting to hear. Eric Hesse has got something to add here.
Yes, just that it's also very important, I think, to underscore what Alan's saying with the point that disorganized attachment should never be used as a proxy or a way of making any fast inferences about the idea that there's been child maltreatment, or that even a parent that's exhibiting frightening behavior is doing something that is really aberrant.
Now, someone who's done some research precisely on this is Mary Dozier. So it would be great if you could just elaborate this in a bit more detail for me. given that disorganized attachment is more common in maltreatment samples, why can't it be used as a screening tool? I don't understand.
Yeah, and emphatically, I think we would all say that it shouldn't be used as a screening tool. Eric alluded to this earlier, that there is evidence at the group level that abuse is linked with disorganized attachment. But that doesn't necessarily tell us anything about a particular dyad, a particular infant and parent. So the problem is there are many children who are abused who don't show disorganized attachment, or who show disorganized attachment who were not abused. And so it's really dangerous to use a screening tool that would screen a child for disorganized attachment with the assumption that that child has been abused. It would be dangerous, and it would be wrong. And I think we feel strongly about that. Another thing that I would just like to mention is that if you ask a parent to come in and be assessed, to be screened for maltreatment, and you're going to put that parent in a strained situation and separate the parent from the child, you can imagine that there could be nothing more stressful for that parent. And it's going to be difficult for that parent to behave as she normally would, and she's going to convey that to the infant. And so I think you have a totally invalid assessment when you are attempting to do a strained situation. It's not the purpose for which this assessment was developed, and we don't have any data to show that it works under those circumstances.
Now, Per Cranquist, you've written in journals and also in the media about the misapplication of the disorganized attachment classification. Can you tell us about your views on this?
Yes, well, I would second what has been said by the previous speakers here, that there have been serious cases of misapplication of disorganized attachment. And I think that the common denominator is that disorganized attachment is being used as an assessment rather than as a foundation for supportive social work, for example. And there's another common denominator, I think, in the misapplication, and that is that disorganized attachment is often being confounded with maltreatment. Or another way to put it is, people seem to assume that maltreatment would be the only cause of disorganized behaviors. And so, again, disorganized behaviors may be displayed, but it doesn't necessarily indicate disorganized attachment, and it doesn't necessarily indicate maltreatment. In fact, in many cases, it doesn't. Like Professor Hesse was talking about earlier, there are multiple pathways besides maltreatment that may lead to disorganized behaviors. So, one problem here is, of course, that there are certain groups of individuals where these misapplications tend to be particularly common. It doesn't tend to happen to privileged middle-class population, but it tends to be against people of ethnic minorities or people suffering from poverty, for example. So what happens there is essentially if a child is removed from those parents because a social worker thinks that he or she has established maltreatment from observing disorganized behaviors, is essentially that the fundamental rights of the parents and the child is being violated. So it's serious forms of misapplication. It's not just a danger for it, there are multiple examples of when that has actually happened.
One of the pieces of research that you've conducted, Per, that really I thought was so interesting was looking at disorganized attachment and parents with learning disabilities. Mm. It might be interesting to hear a little bit about that.
Yes, well, so that is a population that has been severely discriminated and subjected to serious forms of prejudice for many decades, and they continue to be. So there is often an assumption that these parents are completely unable to provide sufficient care, and that there is no reason whatsoever to provide interventions or guidance for them, because they will fail as a natural function of their learning disabilities. What we find in our study is actually that intelligence itself doesn't seem to be associated with disorganization or other forms of insecurity in the child. It is the combination of learning disabilities and the mother having been subjected to maltreatment during her own upbringing that makes her especially vulnerable and also makes the child insecure.
Thank you. So we've heard some warnings about disorganized attachment, that it really shouldn't be used for screening for maltreatment. But really, that then raises a question for clinicians and social workers and those working with families. How can attachment best be used in the context of supportive welfare or clinical work with parents and children? Miriam, can you tell us anything about this?
Yes, I'd be delighted to, because I think this is actually where we have a huge role to play, because we have amongst us some of the people who've contributed greatly to our understanding about attachment. And for a social worker or a clinician working with children and with families, we have a lot to offer. The rich theoretical and conceptual work of John Bowlby in England and Mary Ainsworth in this country have provided us a huge base from which we can actually help guide clinical work. And so I think that that would be the first starting point, is to read some of that, because I think there we find there isn't anything better, I think, available to us in terms of understanding what are the predictors of mental health later on, by understanding that first fundamental relationship that an infant has with mother and with father. And I think we want to bring fathers into our discussion with families as much as we possibly can. The other piece that we have that my colleagues here have contributed to is an incredibly rich toolbox of assessments. They're very technical, but we can learn a lot by both understanding what they've taught us in terms of the rich data set, in terms of how attachment unfolds over time from 12 months, 18 months, 5 years, in through adolescence and adulthood, and looking especially at the intergenerational patterns of attachment, that I think is one of the most exciting places that the empirical research has met the theoretical and conceptual piece. On the other hand, we do find places where clinicians have gone askew and misapplied some of this work by using assessments forensically, that is, to make decisions over custody cases, divorcing couples, or instances where there's a foster care and there's some hint of something perhaps less optimal going on, and using one of these assessments by people who are not trained to use them, who've not been certified to use them, and that is indeed very dangerous. They can be used, and I have used them myself, as part of a much larger assessment battery. So in that case, where there's observations of the child at home, in our lab, or at school, alongside with one of these measures, either the adult attachment interview or the strain situation, adds a whole other complexity to our assessments that we can use in terms of court work and for clinicians. So I think that's very valuable. I think the other place that I often talk to clinicians or social workers about is how interesting that these developmental psychologists have really honed in on some very central clinical areas, and that clinicians might not have arrived at those without the help of these developmental psychologists. So in terms of unresolved mourning, most clinicians would understand that that's very important. But you wouldn't understand necessarily unless you looked at some of the research that some of those very specific indices that you wouldn't be looking for otherwise, we can glean from this. So there's a lot to learn from the research assessments without having to do them yourself. They're far too complicated and costly for us to expect that your social worker, your caseworker, your clinician is going to be able to use these. But that doesn't mean they can't learn from the basis from which they've been developed and from the theory. I think we're all sitting here today because attachment is different from many other developmental tools because it's connected to a theoretical base, and that differentiates it. And I think that's probably why we're ended up in this place that it's been misapplied as well, because there's an excitement about being able to look and observe in this particular way. And it's about the popularity of these constructs because they make sense at the end of the day.
Miriam, that's really interesting. One idea that has come out of that, and that I'm sure listeners will have come across, is the idea of the cycle of abuse. I'd be really interested to hear from Alan about the cycle of abuse what does this idea mean? What's the truth in it? And what might be confusing about this idea?
Well, the starting place is there is a connection between a parent's own history of abuse and the possibility that they will maltreat their own child. There is some connection, but it's very much like we were talking about disorganized attachment. Of course, not every parent who was abused as a child will go on to abuse their own child. There is that connection, and there is the connection across generations, and there are understandable reasons for that connection, because parents who have been maltreated as children and who haven't gotten the adequate help to cope with and deal with that maltreatment are vulnerable to maltreat their children, who then become vulnerable again. But we also have learned things about how that cycle can be broken. In our particular study, what we found were 3 reasons that parents who had been maltreated might not maltreat their children. One was many of these parents got help as children, sometimes in the form of therapy, sometimes in the form of an alternative caregiver. A second reason was some people who have been maltreated formed a relationship with an adult partner who was supportive of them, and that often accounted for the change. And those things taken together are a pretty powerful combination. So we would all say here on this panel that even if a parent had a maltreatment history and they were now having a child, they could be helped to not maltreat their child through the relationship with the therapist and through helping them form other supportive relationships with a partner or with their social network. So none of this is, even though the research shows there are these connections, none of it is a sentence that if you're disorganized, if you have a disorganized attachment as an infant, or if you've been maltreated, you will not necessarily maltreat your own children. People can be helped.
It's marvelous to hear that even just having one supportive friend or a teacher or someone in your life growing up, that can make such a difference. We've also got on the panel people who have been involved in making programmed interventions that can be used clinically. It would be wonderful to hear from them about the interventions that they've designed and what might be learnt from that experience. So Mary, perhaps you could begin by telling us a little bit about the intervention that you've designed and what you've learnt from doing that.
We developed a 10-session intervention that targets 3 things. It helps parents, and this is for very high-risk parents that are at risk for abusing or neglecting their children. It helps parents be nurturing when their child is distressed, so to pick up a crying baby, for example. It helps parents follow the child's lead, which is something that helps children develop regulatory capabilities, and it helps them avoid frightening behaviors. And we do this through 10 sessions in the home through, it's called a manualized intervention, and so they're guided by a manual, and we have specific ways in which we want the parent coaches or the interventionists to work with the parents. And what we found is that this intervention has effects. When we randomly assign to either that intervention or another intervention, we find that fewer children have disorganized attachment in that, what we call ABC, attachment and biobehavioral catch-up, and they have better regulatory capabilities in some ways. Like they can regulate behavior better. They do better in terms of not touching toys that they're supposed to not touch, and things such as that.
What does it mean that there's less disorganization after the intervention? What can we learn from that?
I think what we learn is that this is something that can change. This parents' behavior can change, and then this can have effects on children's outcomes. And so I think, and I know Miriam has also invested in interventions that have effects like these. I think it's very exciting, and what's striking is that this parent, for an infant, the parent is the child's world. And so if you can change the behavior of the parent, you can change this infant's world. and you can therefore change attachment and change behavioral regulation. So it's actually quite exciting and quite doable.
That's remarkable, because an idea that I think is quite common is that attachment disorganization is fixed for life, or indeed any attachment pattern is fixed for life. That you can change that with just 10 sessions is really remarkable. Another intervention was designed by Professor Steele and colleagues, so it'd be really interesting to hear about that.
So our intervention is a little different, although it has some of the same kind of hallmarks. And I think one of the exciting places is that we can change. And as Mary said, for the child, that mother is the most important person in the world. And we know there isn't a parent who wants to be separated and give the child up to the child care system. So our intervention is quite intense. It runs 26 weeks. The families meet in a group, and that is part of the milieu or the context of the intervention. So they meet 3 times a week. Part of the intervention involves a parent-child section where there's a therapist working with the dyad. We're really working on 3 patients, the parent, the child, and the relationship. And so very much the relationship being very central, and that's the place that we're looking to shift things. There's another component where the parents go off and meet together in a group. And for the families that we're working with, which are quite extreme in terms of what they're facing, many of them have suffered trauma in the past. They have at least 4 or more adverse childhood experiences, which we know can make you sick when you suffer those in your own childhood experience. Many of them are living in poverty, and that brings with it a whole range of added stressors: domestic violence, neighborhood violence, and additional stressors over health disparities, and not being able to find a place to live that's adequate. So they discuss some of these in the parent group. The child, unusually in our intervention, I think we're one of the only interventions where there's a clinician working directly with the child. And how that helps is to help the child have an experience of what it's like to be with someone who is sensitive and responsive to them. And they almost transfer that expectation to the parent when we bring them back in kind of an orchestrated reunion. The relationships that the parents make with one another are crucial, the relationship with the clinicians, and even the relationships that the young infants, it's for infants 0 to 3 make with one another, are part of this. It's quite cost effective because it is delivered in a group, and it's combating both the social isolation that many of these families face, as well as really working on the qualities of the relationship that we think we can target by, in the moment, working with them in terms of actually helping them along and seeing things and feeling things to be a little bit different than they would have without the intervention.
That's so interesting. Thank you very much. One thing that it makes me wonder about, though, is that clinicians and social workers might be wondering if they can, with their limited resources, target the child or target the parent or target both. What have you learnt about an answer to that question?
That is an excellent question. I think it's very complicated, and I think in some ways why we're taking such an intensive approach is because these are long entrenched problems, and these cycles of intergenerational patterns have gone on in these families for many, many generations. The ones that we're working with in New York are often the children born to the crack cocaine epidemic of the late 80s and early 90s. So the trauma is kind of entrenched in the system. So I think that in some ways we're throwing the kitchen sink at them. It is a manualized approach, but we are coming at them from many different directions. And I think it takes time. There is something around working so that we can really help them get to a new place in their relationships.
Thank you. Does anyone have any final thoughts or things that they'd like to add in closing?
Yes,
Please.
I was thinking that we were talking about disorganized attachment as a risk factor in development. Professor Strofe was saying a few things. I agree with everything that he said there, that it is established as a risk factor. But I think it's important to keep in mind that disorganized attachment can also be compared with other risk factors in development. And so if we would compare disorganized attachment with severe forms of maltreatment or multiple separations, so the child is being sent to foster home 1 and then foster home 2.
To check, you don't mean a child going to nursery. That's not what you mean by multiple separations.
That's not what I mean. I mean that they changed caregivers multiple times. There is no question that those things, maltreatment, repeated separations, are more serious in child development than merely disorganized attachment in the absence of those. And I think that's important to keep in mind, because when a child is removed from its original family, there will usually be multiple separations happening. Foster family 1, foster family 2, foster family 3, and so on. And that does serious damage to the child's development. It's much better to work with interventions, typically.
Thank you very much. It's been wonderful to hear from all 5 of you. Thank you ever so much. I'd also like to extend my warm thanks to the Wellcome Trust for funding the research and making possible this conversation. And thank you for listening.